healthcare reform has really been reshaping the way many of us think about our healthcare system, and there's just been a lot of increased recognition of the importance of factors that are outside of the traditional clinical healthcare system on both patient outcomes and on population health, things like housing. And so there is also, as a response to this, a growing interest from healthcare payers and organizations who have shown an interest in increasing their investments in the social determinants of health, like housing. But some really important questions remain for both those payers and some of the existing community-based or public health-based programs that have the services that they're interested in providing. So as Philip mentioned, over the past year, NCHH has done some work to really document what the current reimbursement landscape is for some of these healthy home services, and to highlight some strategies that might be available to really leverage this special opportunity to take advantage of the healthcare sector's interest in financing these initiatives. So that's the work I'm going to be sharing with you today. So this was we are currently in year 2, but the project started last year. It's a project funded by the American Public Health Association and the Centers for Disease Control and Prevention, really to answer 2 specific questions. One is to actually just answer the very simple question of what is the current reimbursement landscape? Are people, are payers already reimbursing for services like home-based asthma interventions to reduce triggers in the home environment, or lead environmental follow-up services to eliminate exposure to lead hazards in the home environment? If so, what states are those? Where is that happening? And what does that look like? And then the second question the project really sought to answer was really what opportunities exist for other state and local agencies where those services aren't in place, but there was an interest in putting them into place. What are the opportunities to secure some of that healthcare financing of healthy home services? So to address that second question, the center actually spent the last year bringing together a lot of existing tools and reports, resources, case studies, and developed some new materials into a healthcare financing resource library. I'm not going to be talking about that today, but you'll see a link at the end of the presentation, and we encourage all of you to look at it and let us know if we're missing something, or if there's a topic there that hasn't been addressed that is of particular interest to you, because we see that as a dynamic resource we'd like to keep up to date. There's a lot of good information for actions that can be taken at the state or local level, opportunities for even federal partners to really get engaged in this and help to advance this opportunity. But what I'm going to spend the first part of today talking about is really how we went about answering that first question about where services are already in place. So this spring, the National Center for Healthy Housing, launched 2 online surveys, one focused on documenting state reimbursement policies, really focused heavily on Medicaid reimbursement policies for home-based asthma services. We used a definition from the Community Guide to Preventive Services for these services that is pretty well understood, but it includes really identifying and addressing common asthma triggers in the home environment to eliminate or reduce exposure to those triggers. And a second survey is focused on lead poisoning follow-up services with a definition that the services had to include an environmental component that identified and eliminated exposure to lead hazards in the home environment. We sent the surveys to contacts in each state. Medicaid directors in each state got copies of both surveys, and the program contacts, either an asthma contact or a lead contact in each state at the state health department typically, also received a copy of the survey so that we could try and ensure a response from as many states as possible. In the end, we wound up with responses from 46 states for asthma and 49 states for lead. And here's a little bit about what we found. For the home-based asthma services, we found that about 3/4 of states, 37 states, reported to us that there were no services in place, or the respondent wasn't sure enough to really answer the question definitively, or they were one of the 4 states that didn't respond to the asthma survey. So not widespread uptake of these services. But at the same time, we heard from 13 states that there was some policy in place to reimburse through the Medicaid program for these home-based asthma services. I just want to emphasize it's really important to note that these could be very limited in scale. It could be that one managed care plan in the state is providing these services, so it doesn't mean that the service is widely available to everybody with asthma in the state, but still encouraging that in 13 states there is some policy in place. Furthermore, we heard from 3 states that they didn't have it in place yet, but expected to have Medicaid reimbursement in place for these home-based asthma services within a year of answering the survey. And then 19 states told us that they were actively exploring reimbursement, either putting new services into place where they didn't exist already or expanding services if they already had services in place. If they were one of those 13 states, some of them told us we have it in place, but we're going after a wider scope of services. And so people obviously also want to know where those states are, and you're seeing on your screen right now a map. The states that are colored in red are those 13 states that told us that they had some policy in place to cover these home-based asthma services. And the states with the blue dots in them are those that told us that they were actively exploring Medicaid and reimbursement or an expansion of the services where they were already in place. So we can see that there's a fairly widespread geographic distribution, a little bit missing in the Southwest and sort of mountain time zone, but still some active interest there. I'll also tell you right now that we know that this map is already out of date. These surveys were just finished in the late spring of 2014, but we know that there are other states that have started coming online with pilot programs or actively exploring this. So this is already outdated, but the sort of trend of this growing interest remains the same. The picture for lead was quite different. So what we heard for lead was about just over half of the states said that there was no reimbursement in place right now. But 23 states said that they did have some reimbursement in place for these lead poisoning environmental follow-up services. 18 of those 23 states furthermore said that they had it in place as a required service. So it was either a required element of their fee-for-service delivery system or it was a required element of their Medicaid managed care contracts. So this is a little bit more permanent infrastructure. It's a little more widespread availability than what we saw for the asthma services, but in many cases still somewhat limited in scale. And then also in contrast to asthma, although there seems to be more established services in place for these lead poisoning follow-up services, no additional states told us that they expected to have new services in place within the next year, and only 7 states said that they were considering or exploring either putting new services into place or expanding their existing services. The map for lead follows the same rules as the map that we saw for asthma. The states that are in red are those states that told us they had some Medicaid reimbursement in place for these lead poisoning environmental follow-up services, and the states with the blue dots are those that said that they were actively exploring putting new services into place or expanding their services. You can see for the most part this is concentrated in the eastern half of the country where we have the older housing stock and traditionally some higher burden of lead poisoning, but with some exceptions on the West Coast. So I'm going to go back and forth a little bit and talk a little bit about the states where there were services in place and a little bit about what we found out about what those services look like. So first we asked who was eligible for the services. And among the 13 states that had home-based asthma services in place, and I will say I'm going to switch back and forth between asthma and lead. I'll try to be good about saying what I'm talking about, but there should be little sort of graphical cues up in the corner of the slide to help you in case you get lost between me flipping back and forth. So, but among the 13 states that have the home-based asthma services in place, all of them were providing services to children. But interestingly, the majority of just under 70% were also providing services to adults as well. We asked them what other types of questions or criteria they imposed to determine who's eligible for services. And what we heard most commonly was that healthcare utilization criteria were used to determine this eligibility. Things like a recent hospitalization or emergency department visit for asthma or other healthcare utilization measures. That's typically something like a medication history. Things like an asthma control test score, where the patient lives, allergen testing. We asked about those things, and a handful of states replied for each of those that those were factors that were considered, but not as common as the healthcare utilization criteria. When we asked the same question for lead, these are obviously services that are directed specifically for children, so the eligibility for these services is really contingent upon blood lead level results. But what we found is that the sort of threshold of blood lead level that you have to have in order to trigger services really varied from state to state, all the way from as little as 5 micrograms per deciliter, which is the current CDC reference value for childhood lead poisoning, all the way up to needing a blood lead level of 20 micrograms per deciliter to trigger services. And furthermore, within each state, what we heard is that there might be different levels of services available for different blood lead levels. So one state, for instance, said if you have a blood lead level of 10 micrograms per deciliter, you can have your home assessed and an investigation can be done. But in order for us to pay for the remediation, you need to have a blood lead level of 20 micrograms per deciliter. We also asked what type of services were reimbursable. So we gave them a definition, but many of these services have lots of different components. So we wanted to have a better understanding of what actually was being provided. So among the 13 states that have those home-based asthma services in place, a majority were covering things like self-management education, which includes some information about knowledge of personal triggers, and also the assessment of a primary residence. This is typically a visual assessment. We're not necessarily talking about dust sampling or anything like that, just a visual assessment to look for common triggers or sources of potential triggers. And then also over half were paying for in-home education about triggers that were identified in the home environment. Less than half, but still 38%, said that they were paying for low-cost supplies and services. This is things like mattress encasements to reduce exposure to dust mites, which is a common asthma trigger, or integrated pest management services. This is really interesting because this is typically seen as one of the biggest barriers to reimbursing for these services. So it's interesting to find some examples here where even within the current sort of healthcare system, which is still largely focused on our traditional way of delivering healthcare, that many states have found ways to pay for this. It appears that this is largely happening in a Medicaid managed care delivery system, which offers some additional flexibility. And then we even heard from some states that they're able to pay for things like assessment of a second residence, if, for instance, if a kid splits their time between mom's and dad's house, or structural remediation. When we asked the question about what services were reimbursable for lead, what we heard was that assessment of the primary residence, again, was pretty common. We have some questions about exactly what's entailed in that. Visual assessment is certainly something that's easily reimbursable, but may not be inclusive of other types of typical standard sort of lead hazard assessment techniques. Also things like clinical or nursing case management, in-home education to reduce exposure to lead hazards were pretty common. Less than half, but still a handful of states told us that they were paying for things even though like enforcement activities or lead hazard control activities. Again, we think this is an area ripe for follow-up to figure out how states have been able to put this in place, because that is often perceived as this large barrier. Just pause for a moment for among the 18 states with these required lead poisoning follow-up services, we asked them a further question. There is this set of preventive services called the Early Periodic Screening, Diagnostic, and Treatment Benefit, known just colloquially as EPSDT. That's a mandated set of services that are provided to all children enrolled in Medicaid in all 50 states. And so it has these, this ability for states to define what they call other necessary health services. And so there is been some discussion over the years and guidance issued from CMS about how this can be used to pay for or require coverage of some of this environmental follow-up services for lead. So we were interested to know whether states were actually leveraging this mechanism to cover these services. And so of the 18 states that said they had required services, 11 of them told us that yes, they had the specific policy as part of this EPSDT benefit. The 3 states that told us they didn't, and the 4 states that said they were unsure, it's interesting to us, all of those came from program respondents. None of the Medicaid respondents told us that. So we think this is also an area ripe for follow-up and clarification of guidance. We also asked what type of staff are providing the services. This is always a topic of great interest when designing benefits at the state level. And so what we saw for the 13 states with home-based asthma services in place is that there's a heavy reliance on clinical staff. So the most common answers were professions like nurses providing most or all of the services, certified asthma educators, and respiratory therapists. But we did see some states using community health workers and promotoras, housing professionals, environmental health professionals, and social workers. So definitely some opportunities there to include non-traditional workers as part of the care team. When we asked the same question for the 18 states that had required lead poisoning follow-up services, again, we see a very heavy reliance on nurses as part of the care team to provide some or all of the services, but also, again, really a lot of precedent for using some of these non-traditional, non-clinical workers like lead inspectors, environmental health professionals. So a lot of interest there also. We also wanted to get a sense of how the money was flowing in each state. So we asked some questions about who is typically billing for or getting reimbursed for these services. When we asked this question among the 13 states that had the home-based asthma services in place, again, we see a heavy reliance on sort of this clinical framework. So we see that the most common entities are things like Medicaid managed care organizations, home health agencies, or visiting nurse agencies, hospitals and clinics, with much fewer examples where local health departments or state health departments, for instance, are the ones receiving money to provide these direct services. However, we saw a different pattern when we asked the same question about who's billing for these services among the 18 states with lead poisoning follow-up services in place. Here we see that the most common entities were the local health department and the state health department as providers of these services, and the ones that are able to be reimbursed, and much less reliance on the clinical organizations. So people often want to know these questions about how many visits and how much reimbursement. You'll see there's a big caveat on the screen there. I will just urge you to really take all of these numbers with a grain of salt, because it turns out that this is a very difficult question to answer in a survey because of all the nuances of how services get billed. But for the home-based asthma services, when we asked people how many visits, we heard from most states is that there's not a one-size-fits-all, that there's a range. So instead of saying it's 3 visits, we heard between 2 to 4 visits, between 3 and 6 visits. So there's some flexibility. The overall range we heard reported in the survey was from a minimum of 1 all the way up to 10 visits. I'm personally aware of a payer in this country who pays for up to 18 visits. The survey didn't capture that, but the takeaway here is that there's a range of visits. Similarly, with the reimbursement amount, in this survey we heard a range of $81 per visit up to $200 per visit. Again, I'm aware of payers who are paying for closer to $500 or $600 for some specific visits. But again, there's just a range of funding that may be available. For the 18 states with lead poisoning follow-up services in place, we heard a very similar pattern, a range of visits, so the range here was narrower. We heard a minimum of 1 all the way up to a maximum of 4 visits being provided, but again, it usually was 1 to 2 or 2 to 4 visits. So we heard in most states that a range of visits was possible. And then the reimbursement amount, the range here was much broader actually than we heard from the asthma respondents, from as little as $35 per visit all the way up to $450 per visit. Now, it's important to know that in the open-ended comments, many states remarked to us, remember that the most common billing entities were local and state health departments, so many of them commented to us that this reimbursement amount is not enough to actually pay or offset the full cost of the service. Rather, for them, it's just another sort of diversified funding stream to help them sustain and provide these critical public health services, but it really doesn't cover the full cost incurred. We did ask everybody who responded to the survey, not just those who had services in place, a little bit about what they thought was important for enacting this change. So when we asked them who they thought the most influential groups were, the most common responses that we heard were state Medicaid agencies and federal agencies like CMS, that's the Center for Medicaid and Medicare Services, CDC, HUD, EPA, that they thought that those were important entities, followed by their state programs. So that's a state asthma control program or a state lead and healthy homes program, and advocates within the state. We also gave them an incredibly long list of potential drivers that could be important for change. And I will give you links to, you can see the full set of responses. We asked them to rate each of these drivers on an important scale, where 1 was not very important all the way up to 4, where 4 was really, really very important. And the 4 drivers that really got the highest amount of response from our survey respondents were credible information about potential costs and savings and about potential improvements in health outcomes. And I will just say there that we shouldn't interpret that necessarily as there's a lack of that information. It could be in some cases that it was just really important that the information that's already out there existed, that was an important part of making the case in the states where there were services in place. But that information is important, and getting that into the hands of payers is important, as well as federal funding for those state programs mentioned on the previous slide. I know from my own experience working at the New York State Department of Health, being funded by those programs allowed me to spend some time being a champion for seeking these kinds of policy changes. And then certainly political will and leadership is always of critical importance. I'm just going to say a few words about other healthcare financing mechanisms. The survey focused largely on state Medicaid reimbursement policies, but we did ask a few questions about other types of healthcare financing opportunities. So we, for asthma, when we asked states whether they were aware of any private or commercial payers in their state that were reimbursing for those home-based asthma services, 7 states said that they already knew of at least one payer, private payer in their state that was reimbursing for those services, and another 7 said that there wasn't one yet, but they were aware of at least one payer in the state that was actively exploring putting those services into place. By contrast, only 3 states reported that a private payer in their state was reimbursing for those lead services, and none reported that they were aware of any private payer actively exploring putting those services into place. Similarly, when we asked about mechanisms like hospital community benefits programs, accountable care organizations, social impact bond initiatives, we definitely saw that there were more instances where the asthma respondents were aware of those mechanisms being used to finance home-based asthma services, many fewer examples where they were being used to finance those lead follow-up services. However, we did ask about state-funded programs. We tried to be very clear that we didn't mean programs where it was federal funding or any kind of federal grant, but actually state-financed, state dollars to provide these direct services. We saw that only 12 states said that they had some state funding to provide these services for asthma, but 20 states said that they had state money to provide these direct services for lead. So I'm just going to conclude by sharing, I know I've just thrown a lot of information at you, but just some of our next steps here, because as you know, much information as we gathered from this survey, it's been really exciting to get this information and to be able to get it out and share it. It also raised a lot of questions for us. So one of our key next steps is that we are fortunate enough to have a small amount, a modest amount of continued funding from APHA and CDC this year that will be focused on conducting some interviews with key state-level staff in a select number of states to really clarify some of the questions that were raised and to develop detailed case studies that other states who are interested in putting these services into place can use to understand their lessons learned and to sort of build on that experience. We also are really pleased just to announce, and we're just happy to get this information out there, that we have a new cooperative agreement from the Environmental Protection Agency's Indoor Environments Division to allow us to provide targeted technical assistance and training to states to help them get ready for asthma reimbursement. So we're going to be actively recruiting some states in the first quarter of 2015. If you know somebody in your state that's might be interested in this, definitely be in touch with us. And then we do have some other modest funding in place to support some advocacy and dissemination work. For instance, working with the Centers for Medicaid and Medicare Services to clarify that EPSDT benefit so that more states can leverage it, and really taking some steps to ensure that the guidance and the evidence base that payers use to make decisions about services are updated to include these housing-based interventions. So I'm just going to stop right there, and my information is here on the screen. I'm sure Philip has also shared it with you, and some links on this screen will bring you to not only our resource library, but the second link you see at the bottom there will bring you to the web page where you can see the full report with all of the full findings from the survey, all of the detailed findings.
Thanks, Amanda. That was great. I'm going through now and unmuting all of the callers. So if you have a question, please go ahead and speak right up. The other option is that you can type it in to the little widget down there, and I'll read it aloud. So you are now all unmuted, I believe, so go ahead and feel free to speak up.
Hi, this is Kara Metelliano from Buffalo. I'm wondering, do you have state-by-state profiles for this?
Yeah, Kara, so that's a great question. We do on the website, that was the second link that ended in snapshot on my presentation. and I can email that out to the group. It's on that page. You'll not only find the links to the reports, there's actually a clickable map there where you can click on your state and see what your state's responses were for some of the key questions for both lead and asthma. So you have a little bit of information there. And then, as I said, with the year 2 financing, we're currently in the process of trying to figure out which states to target for those detailed case interviews.
Is New York going to be one of those?
Well, so Kara, you know, given my background and my history with New York, it's definitely in the running. I think we're interested in them. They have some interesting history and mechanisms in place, and I think hearing interest from partners like you definitely helps us to make the case that that's a worthwhile follow-up.
Okay, just let me know what you want me to do.
Will do. Thank you.
Yeah.
Any other questions? Don't hesitate to speak up or type it in, and I'll be happy to read aloud for you if you're feeling shy. Going once, going twice. All right, moving on. Amanda, thanks so much for taking the time today. If you do think of questions after the fact, Amanda can be reached at Reddy, that's R-E-D-D-Y, at nchh.org, or feel free to filter questions through me and I'll pass them along to Amanda. And at this point, I'll go ahead and move on to our next presentation. So next up, we have a discussion of the ROCIS program, Reducing Outdoor Contaminants in Indoor Spaces. And we'll hear from Philip Johnson, who's the Interim Director of the Environment Program at Heinz, and Linda Wigington from Wigington Associates. Philip also directs the Breathe Project Initiative, which focuses on the region's poor air quality and environmental health challenges. And he has a PhD in risk analysis as well as master's degrees in public health and environmental sciences. And Philip, at this point, I'm going to go ahead and change over to your screen. And I'm going to go ahead and mute all of our callers again as well. And Philip, right now on my screen, it looks like you are muted. I'm going to try to unmute you real quick. There we go.
Okay. And I'm going to open up the presentation on my screen.
Perfect.
Sorry about that. Coming
That's
up.
okay.
Okay. Thanks
Great.
for the, you can see?
Yes.
Okay, my apologies.
No problem.
Thanks for the opportunity to present. I consider my remarks in the next 8 to 10 minutes to be sort of prefatory to Linda's. So I'm going to move quickly through some material. And really the take-home message would be that in the Pittsburgh area, we're focusing on the indoor and the outdoor nexus with respect to air quality, and our priority is to build awareness that our indoor environments in part are a function of the quality of our outdoor environment, and that these two environments from a personal exposure perspective are integrated. So I'm going to talk a lot today about ambient air quality and its impact on indoor environments and the ROCIS work that Linda is leading. And I'll start just simply by noting that fine particulate matter is a contaminant of interest. It's an excellent delivery portal of toxic material deep into the human body. These particles get into the deep lung. They get into the blood-gas interface area. The lung surface area is, on an adult, about 50 to 100 meters squared. The skin, by contrast, is about 2 meters squared. So we've got a lot of exposure opportunity and dose opportunity from these small particles. A lung actually looks like a big tree upside down. You've got the trachea on the top, and then you've got the branching and the bronchioles and the alveoli. And so this is how we maximize surface area. How do I advance this slide. Not sure.
Your right arrow should advance it.
Yeah, I'm pressing on my keyboard. Oh, wait, here we go. Okay, thanks.
Perfect.
So fine particulate matter kills about 130,000 Americans a year. It's a pervasive, ubiquitous contaminant. It actually kills far more people a year than smoking because of the prevalence of fine particulate matter in our air sheds. California counted up these numbers back in 2007, and they found that ambient air pollution was actually killing more than motor vehicle crashes and homicides. Folks who are susceptible or at increased risk are the children, elderly, prenatals, anyone with respiratory or cardiac disease, diabetics, and especially those in high exposure scenarios. In the Northeast, when we quantified this, it was upwards of 50% of the population. And the take-home here is that these particles actually also get into the building envelope, especially in environments that are already overburdened with ambient air pollution. There's just more stuff outside, and so there's the chance that it gets inside. There have been studies that have quantified this. It of course varies by the building and by the location and the kind of contaminant. For example, in Seattle, where wood smoke emissions are a big problem in the wintertime, the outdoor generated particles accounted for an average of 80% of the indoor particle concentrations in homes that were studied. Jane Koenig in Seattle actually found that the inflammatory response in children with asthma indoors was a function of the outdoor particles, not the indoor particles. So these are just two studies which kind of make the point of how these environments are integrated. In rural areas with wood smoke, this can be a problem. In New York State, I worked on a study for NYSERDA. We looked at 3 counties, and basically wood smoke emissions were 92% of the fine particulate matter matrix in those rural areas. Of course, it's not just wood smoke. In an urban environment like in New York City, for example, I know someone who used to work in this building, and on this floor, she could smell diesel exhaust from the trucks that were down at the bottom of the building near the air intake. In Pittsburgh, here's a building that has a pre-K program in it, and here's the air intake. And fortunately, they have signs telling the folks not to idle, but it's still a risk. Here's this art installation called Particle Falls that we've got happening right now, and I was standing there looking at this art event, and this truck was just idling the whole time. So, you know, in this urban canyon, that's just not a good idea. So Pittsburgh, here's a view looking north over the Ohio River and the stadiums, and this is the Allegheny River here. On the right-hand side, you can see some nice pollution loading. The left is cleaner. When we compare our particulate matter to other cities, we're in the worst decile. Denver is actually in the 15% cleanest of cities in the U.S. Portland is in the top 15 or 16% in the U.S. Boston is in the top quarter cleanest in the U.S. And Pittsburgh still is really doing poorly in spite of the tremendous improvements over the past 40, 50 years. We're still among the dirtiest cities in the country. In terms of attaining the fine particulate matter standards, we're among only about 60 counties left that haven't yet reached attainment, and over half of the counties in the country reached attainment for the PM2.5 standard over a decade ago. PM2.5 in Pittsburgh is spatially a uniform problem. 7 out of our 10 fine particulate matter monitors are in the worst quarter of the country. And for air toxics, for our industrial point sources, we're literally in the worst 0.2% for air cancer compounds, airborne compounds in the country. This is just a histogram kind of plotting where these monitors are. And our Pittsburgh monitors on the top of those little blue bars to the center and the left and the right of the screen kind of indicate how we compare to the rest of the country in terms of a frequency plot. And here's for air toxics cancer risk on the horizontal axis. You can see the red bars, this bimodal distribution that for Pittsburgh, we have among the highest point cancer risk in the country. And a big chunk of this is actually coming from mobile sources as well as industry. We have a steel mill, a foundry, and 2 coke works, and we still have a lot of metals fabrication. Most folks are surprised to hear this. They think of Pittsburgh as the city that cleaned itself up. That's what it used to look like. This is what it looks like today. We had 65% of the days in 2013 were ranked by EPA in Pittsburgh as days where the air quality was not good. So that's a problem. That's what it should look like. We like to think it's pollution comes from Ohio, but it actually doesn't. The majority of it, upwards of 66% of the pollution in our county, comes from Pennsylvania sources and our own county. And about a third of it is industry, about 40% of it is mobile sources, about 20% of it is actually from wood burning. We have over 32 studies that have quantified using epidemiology associations with excess mortality and disease and adverse reproductive outcomes. Here's a plot of all the chromium, industrial point sources for chromium, and the reason that's relevant is we just had a study, an epi study come out a couple months ago correlating autism spectrum disorders in the first 2 years of life with chromium and styrene levels in our air. Now, of course, these children aren't outside all the time. They're inside. Most of us are inside over 90% of the time. So, you know, these compounds can get inside. The river valleys are actually among the most polluted areas in Pittsburgh. This is where many people live and work and play. They're actually some of the highest levels of black carbon, which is a combustion component of fine particulate matter, is in our river valleys. This is a heat map looking at black carbon. The red basically outlines our 3 river corridors. And so, you know, we think of buildings needing to exchange and pull in fresh air to make the indoor air clean, but our fresh air is actually dirty. And so the conundrum is, if people are inside most of the time, and yet we have thousands of epi studies showing that ambient air pollution is correlated with excess mortality and disease, is it that these people are just getting these exposures during the 10% of the time they're outdoors? No, they're not. Fine particles and other pollutants can penetrate into the building envelopes. And the sum total of our personal exposures reflect these epi associations, not just time spent outdoors. So back in the 1980s, in the wintertime, when most people were inside in Utah, Arden Pope looked at fine particulate matter when a steel mill was running, and bronchitis was elevated, and pneumonia was elevated, and then the steel mill stopped operating, and the particles went down, and the bronchitis went down, the pneumonia went down. Then the steel mill started up again, and the particles went up, and the bronchitis went up in children during the wintertime. The pneumonia went up. And were these kids all inside? Were they all outside the entire winter? No, of course not. They weren't. So we can see this integrated environment and this kind of total sum of exposures. And what we know is that the indoor sources of pollution are significant contributors to air quality. That's so critical. I mean, you know, tobacco smoking and a whole variety of indoor sources can be very problematic where we live, work, and play. But we also know that the total person exposure reflects this entire matrix across these indoor and outdoor environments. And so far as our lung tissue is concerned, these environments are integrated. They're not independent. We know that the building envelope doesn't provide an effective barrier from outdoor pollutants, and that's not just about air pollution, it's also about radon as well. And outdoor air studies are relevant to the assessment of indoor environmental health risks. And we have to be thoughtful about our mitigation measures, and our most vulnerable populations are probably most at risk because of the nature of the indoor environments in which they dwell. So certainly we need clean indoor air, but we also need clean outdoor air because the buildings are inhaling and exhaling this outdoor air. Particularly schools and residential structures, those are probably some of the most porous buildings, and that's actually where our most vulnerable populations typically are. They're not in LEED certified office buildings, they're actually in schools with windows that are open and in homes. So we have to think about this total environment and total exposure framework. We have to think about where our populations live, work, and play, and how they're susceptible in these environments. I'm really inspired by what San Francisco is doing, and I'll wrap up with this. They actually are requiring air filtration in their buildings. They're requiring setbacks of building housing from major roadways and mobile source corridors. They're looking and requiring developers to construct or retrofit buildings with these protective ventilation systems to filter out these particles. And they're making this, they're doing this policy through a public health lens. They're making the public health argument, and they're saying that this is what we need to do. The paybacks are worth it. I think that's pretty cool. And so I'll close with this slide. It's a good quote from Heidegger. Dwelling and building, it's that domain to which everything that is belongs. And so with that, I'll close and let Linda take over. Thanks very much.
Great. Thanks so much, Philip. And rather than, if you have questions for Philip, please hold them until after Linda, because Linda's sort of part 2 to Philip's presentation. And I'll give Linda a quick intro and then hand over the screen to her. Linda is the founder of the Affordable Comfort Conference. She founded it in '86 and was with them until 2013. If you're not familiar with Affordable Comfort, they've been crucial in integrating health, safety, durability, and energy performance into low-income housing. And then Linda also leads the ROCIS project, which she's about to tell you all about. And Linda should have the screen now. Perfect.
Okay, now I'm unmuted. Great, super. I'm Linda Wigington, and I've had the opportunity for the last 6 months to be involved in this initiative, reducing outdoor contaminants in indoor spaces, and opportunity to work with Phil. My presentation has 4 parts. I'm going to lead with sort of a summary of highlights, and then go into the ROCIS initiative in terms of what we've done to date, move into then where are we going, or next steps, and then conclude with key challenges and opportunities as it relates to the broader issue of how we reduce outdoor contaminants in indoor spaces. I'd like to say, just as an introduction, is my background has been focused on building enclosures, energy efficiency, and certainly the whole issue of integrating health with that. It's a strong emphasis of affordable comfort. It's now the Home Performance Coalition. However, outdoor pollution wasn't really part of the radon. Radon was, but not outdoor air quality. So this project has been a major opportunity for me to be challenged and rethink my assumptions, which is pretty neat. Now, right now, my screen's not moving. So, any idea why? Oh, here we go. Okay, so here for my conclusions. I always like to start with my conclusions. These are the key things that need to happen. We absolutely need local champions. There's a huge opportunity to reduce the outdoor adverse effects of pollutants. A whole lot is known, but very little is verified, particularly when you take it all the way from the source strains to the health impact. I mean, we've got gaps and holes all over the place in terms of having a solid path and understanding how to move this forward in a program or systematic way. We clearly need a process in that addressing outdoor pollution is, in many cases, and my focus is on housing, is not a one-time intervention. It might include a number of one-time interventions, but there's a real need for rapid feedback, continual improvement, engaging occupants, having community-based resources as an interface. Right now, there's a huge amount of complexity. If it's a matter of actually coming up with a solution that's going to work, both in terms of the house level as well as the program level, that needs to be simplified. It's a huge barrier. And we absolutely need financial resources, especially right now, perfect timing to get through the proof of concept. There's a lot happening, and getting through the proof of concept in order to demonstrate impact could leverage a lot of resources. But we also, on the long term, addressing low-income populations is not going to pay for itself. It's an area where investment is going to be needed. So, second part, what's ROCIS? The mission of ROCIS is to reduce the impact of outdoor environmental pollution, so that includes air pollution, includes soil-based soil gases and radon, and it also includes pollution that might be carried in via water, particularly water that gets heated, and then, you know, as it's heated, you've got volatiles coming off that water. Primary focus has been air pollution, and lots of those other two become indoor air pollution issues. Our focus has been southwestern Pennsylvania, with the goal of improving healthy and energy-efficient indoor environments. Our focus is on homes and schools. So the goals of ROCIS are to create a collective vision. Well, collective vision, you know, some people get a little uncomfortable about the idea of collective vision. But by collective, we don't mean that everyone that's part of our process is going to have the same vision as much as ROCIS is going to have a collective vision that clearly defines and challenges and, as you could hear from Phil's presentation, just really nails the issue of indoor air quality is a function and is impacted drastically by outdoor sources when they're present. And it's imperative that we bring that into focus and bring that into our views. So the whole notion of the vision is reframing our maps, reframing our paradigm to recognize the incredible importance of doing that. So that's all about what gets people excited, where the motivation comes from is this collective vision. The second is the tool piece. Well, how do you actually give people what they need to take and run with it? So the knowledge and capacity is not just what they need to know, it's also knowing what's known and what's not known, or understanding what makes more sense, less sense, being challenged with misconceptions, and also understanding, well, what's my role? So the capacity of organizations has a lot to do with an organization understanding where it fits in and what it can contribute and how it might need to change in response to this revised paradigm, that's nothing to be underestimated, is that if you change the paradigm, you're then having a ripple effect to how people think about who they are and what they do. Catalyzing collaboration is all about what it takes to get things moving, what it takes to get things funded, and as an essential part. Now, all of these goals have been woven all the way through all of the steps within our process. One of the things we did to get back to that first goal of sort of the collective vision is we realized that as people even heard presentations, a very clear 10-minute or half-hour presentation, it was clear to me that people could come away with different takeaways. It's still like 5 blind men and the elephant. If you interviewed people as they were leaving a meeting, they might come to very different conclusions. So in planning the forum, and basically we had stakeholder meetings and we had a forum just last week, planning the forum had a leadership team of about 15 folks. We felt it was very important to clarify these core principles so folks could feel like they knew where they were, and we sort of had a more common clarity regarding understanding the issue of outdoor pollutants and indoor air quality. So that's a living document. The link is there. All these are ROCIS. This is on the What is ROCIS page. But I welcome your input and feedback on that. So it's an evolving document. The first deliverable for the ROCIS project was 2 white papers. The first draft for the Holmes paper was done in July and was shared at a stakeholder meeting, and then the second commercial paper was done in September. But this is half of our team. It's a dream team as far as I'm concerned. I don't know how many of you know these folks, but Don Fugler spent most of his career with CMHC, the Canadian Mortgage Housing Corporation, where he managed residential research addressing air quality, health, building durability, ventilation, energy efficiency, the works. And Tom Phillips spent most of his career at California Air Resources Board, CARB, where he managed research of the whole nexus of buildings and health. So both of these guys have decades of experience, know what's been published, and are great at interpreting because they manage research projects. So they really did, I thought, a fantastic job of pulling together the 2 white papers. Now, one thing to note is that the white papers are not focused on southwestern Pennsylvania. There was a very deliberate attempt for the scope of the white papers to be the United States and Canada, and to address sources and issues across all of those. So the white papers fed into the stakeholder meeting. The idea was that the content, the summary of the white paper would help to contribute to the knowledge base, the understanding. Stakeholder meetings involved about 50 folks. They were a diverse group. We met for half a day with lunch. We blended presentations, a whole group discussion. It's an incredible dynamic conversation. The group is pretty informed and motivated, but we're also challenging them. We're constantly challenging to rethink their view, their paradigm, and include outdoor pollution as an integral part of indoor air quality. We also had a lot of small work groups to work through things. So we really tried to contribute to all the levels of the ROCIS goals that I identified to create the mission, the clarity of the vision, to build capacity, to clarify what the organization's roles are, and to enhance collaboration. So we had a pretty good blend of groups that we considered core. Lots of, the folks involved in delivering energy efficiency at the residential level, the folks involved in sustainability, some of the folks involved in affordable housing, certainly a local government from City of Pittsburgh and the county, good nonprofit representation of environmental advocacy groups, some private contractors. Pittsburgh is blessed with incredible university community, and we had research staff. We did not have consistent representation of health providers or building school officials, public school officials. And one of the concepts that we developed fairly early on was that, well, if you don't get who you want, what you need to make sure you got is somebody who sort of knows the culture, or culture might be the wrong word in some people's minds, but I like to think of culture as the sector that a person represents in terms of the way they think, the way they talk, what motivates them, how they function. And you need people that can cross into and communicate and engage. So bridge people are the folks that have one foot in our camp, our broad camp, perhaps, and then another foot among the health providers or working in the public schools. So that's sort of one way of compensating. And looking at what we did, it's very clear. I did have a lot of one-to-one meetings, but having more one-to-one meetings early on could have made a difference. Once your initiative is formed and you sort of have your core group of who's coming, it's very, very difficult to bring in new folks, because when they look at who's involved, it looks like somebody else's gathering. It looks like somebody else's party, so to speak. So it reinforced to me what I've learned through lots of planning events, is that you really got to get the representation you want at the beginning in order to leave the door open to involving more folks as you go forward. That's a tough one. Well, we had the second stakeholder meeting in September, and I plan to follow up fairly soon with a forum that would be the next step in our process and develop initiatives. But because of timing, the forum got kicked back into December. We wanted to maintain momentum, so what we did was we got our contract adjusted and added a two-part webinar series on particles. So this was with the intent of continuing to build the knowledge base to raise more awareness and recruit more people into the December forum. I also have an opportunity to plug the ROCIS white papers. And we did this immediately before the forum because we really wanted people to be able to benefit from it. We didn't want it after the forum. The whole idea was to maintain and sort of fill the November gap. So the dates were what you normally would avoid if you were planning a webinar, and yet Friday afternoon before Thanksgiving, we had 86 folks participating, and Tuesday afternoon of Thanksgiving week, talk about a time that, why would anyone schedule anything Tuesday afternoon of Thanksgiving week? We had 54, which we were thrilled with that level of participation. Half of the folks were from southwestern Pennsylvania. We didn't actively recruit outside of southwestern Pennsylvania, but we sent information out to a few folks, and that got into some other channels. So obviously the attendance could have been much higher if we had tried to really recruit a broad audience. But I thought what was very interesting is the blend of who we have here. Clearly folks involved in policy end, research, lots of PhDs, university, government type folks. And yet we also had a very healthy representation of folks that were dealing with stuff on the ground. So it was a very, very diverse group and very good feedback from those webinars. The first one was by Brent Stevens and really focused on his doctoral work at the University of Austin, where he looked at what happens between outside and inside if you measure particulates in a very controlled way in 20 buildings, and really look at all the factors influencing how outdoor particles get indoors. So the whole issue of house tightness, house pressures, the effectiveness of ventilation systems, the operating time of ventilation systems. So really practical stuff for our audience. Our audience tends to be pretty pretty nerdy in terms of understanding how homes work. So it was great content for that. And then the second webinar was broader in focus. Bill Turner was involved in the original 6-city study that Harvard did years ago, the longitudinal study, but he's been around for quite a while, and his presentation really sort of filled in the gaps in terms of understanding health impacts of particles, the standards and monitoring equipment that's available, and then a broader view of what we can do to mitigate, not just focused on outdoor pollution. So these the PDFs and the MP3 and MP4 are all on our website. So by all means, check those out, share them with others. So that gets us to our forum, which was just last week. 50 people came together. The goal was to begin to develop actionable initiatives. So we went through a process of brainstorming and sharing and I'm getting ahead of myself here, and then discussing them in small groups. But one of the objectives in order to really lay the groundwork for the initiative was to clarify what we already have represented in the room in terms of experience. So we had 2 lightning rounds featuring 16 presenters, 13 projects. It truly was a lightning round. People did only speak for 3 minutes, and it really conveyed the strength and the diversity of the local resource. And up to that date, in our 2 previous stakeholder meetings, we really didn't give the floor as an agenda to local initiatives. So we felt it was very important to recognize that, because you need to know who's doing what in order to better understand the whole issue of collaboration and initiatives and building on those initiatives. So then in developing initiatives, we dug deeper into 10 after we had brainstormed on about 25. We've got a final report that's due in another month or 2. We plan to have another stakeholder meeting or a celebration. But this is just a summary of those initiatives that emerged, and there'll be more information on our website addressing these. But you can't tell a whole lot from some of these titles, but there's a very interesting variety. And in some cases, we were building on things that are already happening. In other cases, we were coming up with stuff that would be brand new. But all of these involved a pretty significant level of collaboration across nonprofit, local government, and university. So into this makes it the third part of my presentation. So the key challenges, back to, okay, okay, that's ROCIS, that's what we're doing. We actually provided some clear guidelines in developing those initiatives to include rapid feedback, to include monitoring, to include a number of sort of definitions to look at impact, to look at lessons learned. But at this point, I'm addressing what I see, having thought through and worked through the white papers. I thought through many discussions of, well, how do you take what we know and actually put it into practice and move it into the field so that we're actually having impact? A huge issue is that most things require maintenance and operation. Most solutions are not just a technical whiz-bang, install it and you're done and you never have to look at it again. And it's really hard, particularly among vulnerable populations, to figure out how to address that, how to deliver and support something that requires ongoing maintenance and operation, even if it's only a year. Operation might just be turning it on or off, but maintenance might be changing filters or whatever. The complexity of outdoor and indoor sources is fascinating, but there can be positive synergy or there can be negative synergy, and it became very clear that you gotta keep your eye on both. You got to understand the variability in the sources, and in many cases, indoor sources are driven by behavior. In some cases, they might be just a function of only having a gas stove and not having any other alternative. But there are many significant sources that are in both places. In southwestern Pennsylvania, we're blessed with a good signal from outdoors. Almost anywhere you're going to get a signal. The question of whether or not you get a really strong signal might depend on what airshed you live in, what valley you live in. But huge issue of how you make sure as you do something to address one thing, you're not creating a confounding problem that makes another problem worse. A good example would be if you weatherize homes and really reduce the need for an air conditioner, because you're really bringing the solar gains down. You might have a house that does use room air conditioners or central air conditioner that provide a certain amount of filtration. Well, now they might not need that, and because they're not using that, they're not getting the filtration they were before, and that might be on both on the heating and cooling side. So there are all kinds of interesting things that could go both ways. So lots of fun. At least that's what I consider fun. The other one is reservoirs. Now, we tend to think about, okay, you got indoor stuff and you got outdoor stuff. But then you've also got, particularly in an industrial old towns, you've got this huge issue of acquired things, things that are acquired because they've been tracked in the carpet or in the furniture. I've seen attics with a half-inch of this black soot. Ducts are full of all kinds of things that have settled out. So huge issues regarding reservoirs. You can't just talk about controlling the sources. You've got to think about reservoirs. There is not clear guidance on intervention. We absolutely need clear guidance so it's easier for somebody to know what are the right applications for this. How do you decide? What's this cost? What's this look like? What can you expect? Lots of work to be done there. Substandard housing stock is just overwhelming, and the problem is it's so easy to say, well, we can't do anything because we can't solve these, the wet basement, the gas stove, the totally leaky house with a roof that's falling, that leaks like a sieve. Therefore, we can't do anything. It's a walk away. Well, no, we need solutions that address, that at least help houses at all levels. The monitoring that we're beginning to see is not fully developed. So even though it's a huge opportunity in particulate matter counters, there's a lot of bugs to be worked out. So that might end up being challenging. And then there's a need to really document the co-benefits, because there are a lot of co-benefits. We're going to need those co-benefits to be able to make a case for doing this. So I addressed some of these things at the beginning, but wanted to repeat. We absolutely need local champions, and we need to support their development, both with access to external experts, as well as, in some cases, just to overcome misperceptions. We absolutely need this continuum of intervention strategies. So in some case, a window air conditioner unit might be a very good solution, because that way they can close their window. In other cases, a whole house repair. We absolutely need a process. One time's not going to work in many cases. You need to engage occupants. You need to be tracking and seeing what's happening. We need the continuous feedback that we can get. CMU has a lab called CREATE, and it's all about putting great tools in people's hands, empowering citizens, and the spec monitor is a really neat monitor that's in the process of going into production for Phil, I think it's, what, $200, maybe $299, but cloud-based. That's a game changer, huge stuff. We've got to address the cost barrier, and it's not just low income that have cost barrier, but the idea of loan, lease, financing are really huge. And we need continual improvement at all levels, not just at the house level, but at how do we create the systems to get the work done. Now, we asked the question, and this is the part going forward. Okay, so this is the last piece. What's ROCIS going to be when we grow up, so to speak? We're only 6 months old. We asked folks, well, what's going to be valuable to our mission? What would you recommend that we consider? And the red and the blue were the things that folks rated as high as medium. And this was the number of people that returned the surveys was less than 30. So this is a pretty high rate of responses that are very favorable to all of these things, but certainly access to technical resources, communication, guidance documents, are all at the top of the list in terms of things that people think are needed in order to keep what we've done viable and keep it moving. And these are the questions that I have. Phil and Norm Anderson, who's the fourth part of our leadership team, are addressing as we think, well, where do we go from here? The ROCIS initiative is through, the first phase is through February, so we're looking at the next step. How do we most strategically support and empower, and in some cases correct misconceptions, for local champions? I mean, what does that look like? What does that mean? And how do we support the viability without creating dependency? How do we make sure we're really, building on the capacity that's already in Pittsburgh and southwestern Pennsylvania? And then what are we? Is it appropriate for us to lead initiatives, or should we back out of that role? And then is there a broader geographic role with collaboration across U.S. and Canada in terms of presenting some of this information, sharing it at conferences, convening working groups, getting funding to develop some of the key pieces that are gaps? So those are some of the key questions we have been thinking about next steps. So again, the goals: collective vision, knowledge and capacity, collaboration, basically changing the paradigm so we recognize that outdoor pollutants are incredibly important to indoor air quality, and with climate change in many communities growing more so, not less so. It's been a real privilege to be able to work with Phil and the Heinz Endowments, and I'm 60, so for me to be able to be really challenged in what I think I knew and what I know is just it's a delight, as well as feeling like I've had the opportunity to have some impact and move this forward. So thank you very much, and we welcome your questions and comments.
Linda, thanks so much. That was excellent. And Philip, thank you as well. I'm going to go ahead and unmute everyone, so please feel free if you have a question, just like last time, speak up, or if you're feeling shy, definitely type it in, and I'm happy to read for you. But go ahead. I'll give you guys a second to think about any questions you might have. Philip, I might go ahead and ask if you had anything you want to follow up with after Linda's piece.
Yeah. I think that the thing that we're really seeing as important to think about is hotspots in areas where we know buildings are close to overburdened air sheds, and how can we do a better job of helping those buildings manage their indoor air quality? We're seeing this not only in urban areas, but we're also seeing this in our rural areas where hydraulic fracturing is occurring. The air pathways from proximity to well pads and waste freshwater ponds and compressor batteries is really profound. And people who live close to these areas, we just finished an EPI study from Yale University, their risk of dermal outcomes, adverse dermal outcomes, and adverse respiratory outcomes are quadruple and double within a kilometer of an industrial fracking operation, compared to an area within 3 times that distance. So here you have indoor residential environments where people are statistically experiencing outcomes from most likely air pathways. And we need to help these people manage their air quality and manage their indoor environment in a way that handles the external inputs. So this is pretty relevant stuff probably for many parts of the country. And if I had to expose a bias, I think that one of the reactions and tendencies that folks in the green building movement have is like the way they've quantified energy flows and efficiency flows. They want to, I think they want to, some colleagues want to see every last little study that can map out every last little personal exposure and develop cohorts and track people and figure things out. And I think I have a different philosophy on that. Even though I'm a scientist, I think that in some ways it's so clear that these outdoor contaminants are getting indoors. At a minimum, they're a nuisance. At a maximum, they're exerting health impacts that common sense shows that is likely occurring. And really, you know, I would be happy if the architects and the building engineers and scientists and the health people who think about indoor environments started to demand that our outdoor environments get cleaner so that they can help the indoor environments when they do their air exchange. So I'll stop there.
Great, thank you. Any other questions out there? All right, well, I will go ahead and wrap us up then. If you do think of questions afterwards, by all means, email them my way, and I will share them with Amanda, our first presentation, or Linda or Philip. Thanks again for taking the time to join us today, and thanks as always to the Kresge Foundation for providing funding that runs the Health and Housing Funders Forum. Our next webinar is on January 21st at 2 p.m. As of now, we'll have Matt Ammon, who's the new director of HUD's Office of Lead Hazard Control and Healthy Homes, speaking to us. And we're looking for 1 or 2 other presentations, so if you have something you'd like to present or have seen something recently you think would be interesting to the group, by all means, send it my way. And thanks again for joining us today. Please don't hesitate to call or email if you have any questions, and enjoy the rest of your week. Thanks.
Thank you.
Thank you.
Thanks so much.